Hello everyone, welcome to chapter 15. Today we're going to talk about the autonomic nervous system. My name is Professor Droude, and let's get started. We are consciously aware of many of the activities that our nervous system controls and that we've discussed in the chapters before this. Things like the general and the special senses, our cognitive thinking processes, emotions, your voluntary movements. Those things we are aware of, but there is another branch of the nervous system that operates at the unconscious level without us willing it or even being able to modify it. And this is the autonomic nervous system, and that name itself means self-governed, and you can think autonomic, automatic, and it's the part of the peripheral nervous system that is responsible for, as the name implies, regulating the involuntary body functions like heartbeat, blood flow, breathing, and digestion. And this guy, Walter Cannon, was the first to discover it and sort of talk about it as a division of the peripheral nervous system. So the autonomic nervous system could narrowly be defined as a motor nervous system that controls glands, cardiac muscle, and smooth muscle. And so for that reason, it's also called sometimes the visceral motor system, so that you could distinguish it from the somatic nervous system, which controls the skeletal muscles. And the autonomic nervous system in general is responsible for the body's visceral reflexes, which are unconscious, automatic, stereotyped responses to stimulation involving visceral receptors and effectors. And now this is going to sound a lot like the somatic reflexes that we already spoke about, but the difference here is just that they involve visceral receptors and effectors, and they also have slower responses. So the visceral reflex arc in this example here includes receptors like nerve endings that can detect stretch or tissue damage, blood chemical change, and body temperature, and various other internal stimuli. Afferent neurons that lead to an integrating center, and interneurons in the central nervous system. And then efferent neurons that carry motor signals away from the central nervous system to, finally, an effector that carries out the end response. One example that you see in this image here, and that we've talked about before, is the baro reflex, which can detect high blood pressure, which would stimulate stretch receptors called the baroreceptors in the carotid artery. That transmits signals via the glossopharyngeal nerves to the brainstem, which then can go on and make a decision in the medulla to integrate this info and transmit signals back to the heart via the vagus nerve. The vagus nerves slow down the heart and they reduce blood pressure. And this is an example that we used for a negative feedback loop. Okay? So once again, just to remind us where we are here, the central nervous system is comprised of the brain and the spinal cord. The peripheral nervous system are the motor and the sensory neurons that are outside of the central nervous system. And we said that both the somatic and the autonomic nervous system can be broken down further with motor neurons, and then you could further break down the autonomic nervous system into sympathetic and parasympathetic. So we are talking about the autonomic nervous system right now. Let's talk about the further divisions here. So these two subdivisions, the sympathetic and parasympathetic, they differ in both anatomy and function, but they often can innervate the same target organs, and they might have a cooperative or they could have a contrasting effect on them. So the sympathetic division is basically adapts the body for physical activity. So it does things like increasing alertness, increasing your heart rate, increasing your blood pressure, increasing your pulmonary airflow or how fast you're breathing. Blood glucose concentration gets increased, and blood flow to things like the cardiac and the skeletal muscles. And at the same time it does that, it also reduces blood flow to the skin and the digestive tract. And so Walter Cannon, he referred to these extreme sympathetic responses as the fight or flight reaction, because this often comes into play when animals have to attack or run away. And in our lives, it certainly comes into play in similar situations. things in which you feel like you need to fight or flight. The parasympathetic division, by comparison, has an opposite calming effect on many body functions. And it's associated with reduced energy expenditure and normal body maintenance. And this is often where you hear resting and digesting. Okay? But that is not to, so these were like the extreme examples of what the sympathetic and parasympathetic divisions do. And that you might think, oh, so they're only active if I'm doing those things. And that's not exactly true, because just because they seem to have those opposite effects, it doesn't mean that the body like alternates between states where one is active at a time. Normally, both systems are active at the same time. They just exhibit a background rate of activity called autonomic tone, and they balance the shift, the balance and the shift between the parasympathetic tone and the sympathetic tone will shift with the body's needs. So, the parasympathetic tone maintains smooth muscle tone in the intestines, and it holds the resting heart rate down to about 70 to 80 beats per minute. And the sympathetic tone keeps blood vessels partially constricted and maintains blood pressure. The sympathetic division can excite the heart, but inhibits the digestive and urinary function, and the parasympathetic, of course, has the opposite effect. Now, it just depends, do we need more or less of each of them? Okay, so although we define it as part of the peripheral nervous system, the autonomic nervous system actually has components in both the central nervous system and the peripheral nervous system, because it includes control nuclei found in the hypothalamus and other brainstem regions, motor neurons in the spinal cord and the peripheral ganglia, and nerve fibers that actually travel through the cranial and spinal nerves. And so let's talk about that pathway. Let's compare the autonomic nervous system pathway to the somatic motor pathway. The autonomic pathway to a target organ is actually quite different from the somatic motor pathway, because in the somatic motor pathway, and what you'll see in the next picture here in an image, it might be easier to look at, is that a motor neuron that comes from the brainstem or perhaps the spinal cord actually issues a myelinated axon all the way to the skeletal muscle. In autonomic pathways, the signal travels across two nerve fibers and across a synapse in order to get to the target organ. And where those two neurons meet is called an autonomic ganglion. The first fiber is called the preganglionic neuron, and it has a soma that's either in the brainstem or the spinal cord, and then it issues a myelinated axon extending from the central nervous system to a second motor neuron where it releases a neurotransmitter called acetylcholine. We'll learn more about that at the end of this lecture. The second is called the postganglionic neuron, whose neurosoma is in the autonomic ganglion and whose axon extends the rest of the way to the target cell and releases either norepinephrine or acetylcholine. Again, we'll learn more about those at the end of this lecture. Here's what that looks like in image form. If you look at A, that is the somatic motor pathway. It extends a motor nerve fiber all the way from the central nervous system to directly impact the effector. In this case, the somatic effector is a skeletal muscle. B, you see a sympathetic motor innervation, and you see that a short preganglionic fiber extends from the spinal cord to a sympathetic ganglion, usually near the vertebral column, and then a longer postganglionic fiber extends from there to the target. And then in the parasympathetic nervous system, you get a long preganglionic fiber that extends from the central nervous system to a ganglion that is in or near the target organ, and in that case, a short postganglionic fiber completes the path to the effector. Okay, let's move along and talk a little bit more about the sympathetic division. The sympathetic division is also sometimes called the thoracolumbar division because it arises from the thoracic and the lumbar regions of the spinal cord. It has relatively short preganglionic and long postganglionic fibers. The short preganglionic neurons the axons are myelinated, and the long postganglionic axons are unmyelinated. The preganglionic neurons are found coming from the lateral horns and the nearby regions of the spinal cord gray matter, and those fibers exit the spinal cord by way of the spinal nerves T1 to L2, sometimes L3. They have many synapses between the pre and the postganglionic neurons, and the first one we'll talk about are where the autonomic ganglia are, is the sympathetic chain of ganglia. And this allows for the sympathetic nervous system to affect all areas of the body, not just the thoracolumbar division. So here is the sympathetic chain of ganglia, and it's basically a longitudinal series of ganglia that lie adjacent to both sides of the vertebral column, from all the way from the cervical to the coccygeal level, and they are interconnected by longitudinal nerve cords. And essentially, each of the paravertebral ganglion can be connected by branches called communicating rami. So if you look in the thoracolumbar region, each of the paravertebral ganglion is connected by these two little branches, and those branches are called communicating rami. And so I'll show you this in the next image, so it'll be a little clearer. But the preganglionic fibers are small myelinated fibers that are able to travel from the spinal nerve to the ganglion by way of what is called the white communicating ramus. The postganglionic fibers leave the ganglion by way of the gray communicating ramus. They are, if it's white, it is myelinated. If it is gray, it is unmyelinated. This ramus returns to the spinal nerve, and then the postganglionic fibers will extend the rest of the way to the target organ. Let's take a look at what this looks like in image form. Here you see actually three numbered routes that sympathetic fibers can follow. Number one is what we just talked about, that spinal nerve route. The second is the sympathetic nerve route, and the third is the splanchnic nerve route. So let's talk a little bit more about these. But before I move on from this slide, I want you to see that this is the white ramus, and behind it is the gray ramus. So it enters through the white and exits through the gray ramus. And now we can talk a little bit more about the three routes. The spinal nerve route, this is the route that you take to most sweat glands, your piloerector muscles, and the blood vessels of the skin and the skeletal muscles. So this is the one that we talked about, where some of the postganglionic fibers exit by way of the gray ramus. They return to the spinal nerve and they travel the rest of the way to the target organ. The other options are the sympathetic nerve route or the splanchnic nerve route. So, okay, let's talk about that. Some leave by way of sympathetic nerves that extend to the heart, lungs, esophagus, and the thoracic blood vessels. These nerves can form what is called the carotid plexus, which you find around each carotid artery of the neck. And then they issue fibers from there to effectors in the head. Things like sweat glands, salivary glands, nasal glands, the piloerector muscles, blood vessels, the dilators of the iris. Some fibers of the superior and the middle cervical ganglia also form the cardiac nerves to the heart. Some fibers that arise from the spinal nerves, which are T5 to T12, pass through the sympathetic ganglia without synapsing, and they continue on as what are called the splanchnic nerves, and they lead to a second set of ganglia, which are sometimes called the collateral or prevertebral ganglia, and they synapse there. Okay, let's talk a little bit about those collateral ganglia. The collateral ganglia contribute to a network called the abdominal aortic plexus, which is wrapped around the aorta found in the abdomen, the abdominal cavity. There are three major collateral ganglia in this plexus: the celiac, the superior mesenteric, and the inferior mesenteric ganglia. They are located at points where arteries of the same names branch off the aorta. The postganglionic fibers then accompany those arteries and their branches to the target organs. You'll sometimes see this term, the solar plexus. Solar plexus is the collective name for the celiac and superior mesenteric ganglia, because the nerves that radiate from the ganglia look like rays of the sun. Okay, there is It's important to note here that there is no simple one-to-one relationship between pre- and postganglionic fibers in the sympathetic division. Each preganglionic cell could branch and synapse onto 10 to 20 postganglionic cells. So what that means is that one preganglionic neuron can excite multiple postganglionic fibers, leading to different target organs. And this could obviously lead to relatively widespread effects. And that's going to be different than what I'm about to talk about now, the parasympathetic division. The parasympathetic division is also called the craniosacral division because its nerve fibers arise from the brain and sacral regions of the spinal cord. The parasympathetic division has long preganglionic fibers. They reach almost all the way to the target organ, and then short postganglionic fibers that cover the rest of the distance. Parasympathetic division is relatively selective in the stimulation of the target organ, so there's only just a little bit of neural divergence, which means that there's like this ratio of only 5 postganglionic fibers to every 1 preganglionic fiber when we were talking 10 to 20 in the sympathetic division. These emanate from the brainstem, including the cranial nerves 3, which is ocular motor, the 7, which is the facial nerve, 9, which is the glossopharyngeal nerve, and 10, which is the vagus nerve. The oculomotor nerve does things like narrow the pupil and focus the lens. The facial nerve does things like help your tear, your nasal, and your salivary glands. The glossopharyngeal nerve helps the parotid salivary gland. And the vagus nerve does things like viscera as far as proximal half of colon, the proximal half of the colon, the cardiac, the pulmonary, and the esophageal plexuses. And it gives off anterior and posterior vagal trunks. Okay, let's talk a little bit about this overall view, the differences between sympathetic and parasympathetic. In the sympathetic system, the ganglia are next to the spinal cord, whereas in the parasympathetic, the ganglia are close to or on the target organs, which means that in the sympathetic, we have short preganglionic neurons and long postganglionic neurons, and in the parasympathetic, we have long preganglionic neurons and short postganglionic neurons. So now let's finish up and talk about the neurotransmitters, only about 7 slides left here. As an overview, let's say, as I said earlier, the divisions of the autonomic nervous system often could have contrasting effects on the same organ. The sympathetic division speeds up the heart, the parasympathetic slows it down. But each division can also have contrasting effects on different organs. So the parasympathetic is able to contract the urinary bladder, but then it also relaxes the urethral sphincter. Both of those are necessary for urination, and both of them are done by the release of a neurotransmitter called acetylcholine. So how can this be? Well, the reason for it is that, one, sympathetic and parasympathetic fibers secrete those different neurotransmitters, acetylcholine in this instance, and then the target cells will respond in different ways to those neurotransmitters depending on what receptor they have. So all of the autonomic fibers secrete either acetylcholine or norepinephrine, and each of those neurotransmitters has 2 major classes of receptors. Let's again take a look at a little bit of a preview here. So in a parasympathetic fiber, you have a preganglionic neuron, acetylcholine gets released, and the postganglionic neuron could have a nicotinic receptor, which we'll talk about in a second, that then stimulates the postganglionic neuron that then releases acetylcholine again onto a muscarinic receptor that is on the target cell. You also see a sympathetic adrenergic fiber, which again is the release of acetylcholine but has a long postganglionic fiber, and norepinephrine gets released here. And finally, a sympathetic cholinergic fiber, which is going to release acetylcholine at both ends. All right, let's move along and talk a little bit more about acetylcholine. So acetylcholine, of course, is a neurotransmitter, and it's secreted by the preganglionic fibers in each division and the postganglionic fibers of the parasympathetic division. If you go back 1 slide, you'll see that. Also, somatic efferent neurons only use acetylcholine. So somatic nervous system stimulation always excites the effectors, which are the skeletal muscle fibers, but stimulation by the autonomic nervous system can either inhibit or it could excite the visceral effectors. So acetylcholine binds receptors called cholinergic receptors, and there are two types: muscarinic receptors and nicotinic receptors. Muscarinic receptors are always found on cardiac muscle, smooth muscle, gland cells, and they can be excitatory or inhibitory because there are subclasses of the muscarinic receptors. The other type are nicotinic receptors, and they're found on all of the autonomic nervous system postganglionic neurons, in the adrenal medulla, and at the neuromuscular junctions of skeletal muscle, which we'll learn when we talk about the skeletal system. These are excitatory when acetylcholine binding occurs. Only excitatory. Now we could talk about norepinephrine. This neurotransmitter is secreted by nearly all of the sympathetic postganglionic fibers. The nerve fibers that secrete norepinephrine are called adrenergic fibers, and there are two principal kinds of the receptors, which are called adrenergic receptors: alpha adrenergic receptors and beta adrenergic receptors. Alpha adrenergic receptors are usually excitatory, and there are two subclasses that use different secondary messengers, which are the first are the alpha 1, which are blood vessels, and the alpha 2, which are the platelet membranes. Just have to remember alpha 1 and alpha 2. And then the beta adrenergic receptors are usually inhibitory, and there are two subclasses that have different effects, but they both act through the same secondary messenger, which is cyclic AMP. The beta 1, which are in the cardiac muscles, and the beta 2, which you find in the bronchioles and the smooth muscles of coronary arteries. Now let's talk about blocking agents. And blocking agents are what happens when the neurotransmitter gets denied access to the receptor binding sites. And I know this slide's a little messed up, but that's what it says. And let's move on and talk about them. So blocking agents, if you have an anticholinergic agent, this is a substance that blocks acetylcholine. These agents inhibit parasympathetic nerve impulses by blocking the binding of acetylcholine to the receptor. And then beta adrenergic blocking agents, also called beta blockers, are medications that help you to reduce your blood pressure through blocking the effects of the hormone epinephrine, also known as adrenaline. When you take beta blockers, your heart will beat more slowly and with less force, thereby reducing blood pressure. Adrenergic blockers, they block receptors for epinephrine and norepinephrine. Alpha 1 blockers, something called phentolamine is the drug that does this, and that decreases blood pressure through vasodilation. And then beta blockers, one called atenolol, decreases heart rate, and you take it normally after a heart attack to control hypertension. Lastly, we'll talk about nicotinic cholinergic blockers. One example is this drug called Curare. I don't know if I'm saying that right, but it is a relaxation paralysis drug. And what it does is it competes with acetylcholine for the binding site. And you will see people that live in the lesser developed world, like people that live in the jungle, they will use this as a general anesthetic, so it actually knocks you out. It's basically used to describe the name Curare is a plant-derived poison, and you find it with the indigenous South Americans that they use it, and it's this neuromuscular blocker that's basically used like a general anesthetic. And you can do a lot of things when somebody is under general anesthesia. You could do things like a tracheal intubation, provide skeletal muscle relaxation during surgery, or to help with mechanical ventilation if somebody's not breathing. The last are the muscarinic cholinergic blockers. These, of course, block the muscarinic receptors for acetylcholine, and this blocks the parasympathetic effects like nerve agents and pesticide exposure can do this. The drug atropine can do this. It dilates pupils, decreases salivation, and decreases respiratory secretions. And so that's it. That's being said, we've finished chapter 15, and I'll see you in chapter 16.